new people will start to trickle in. Thank you, Monty. So to start us off, we've got Dr. Vito Rebecca, who earned his biology degree at Lafayette College in 2009. He moved to the University of South Florida to the lab of Dr. Kieran Smalley, where he earned a PhD in 2014 in cancer biology for work in proteomics and therapy-resistant mechanisms utilized by BRAF wild-type cutaneous melanomas, a patient cohort that we've seen that has no currently approved targeted therapies. He completed a postdoctoral fellowship at the University of Pennsylvania in the lab of Dr. Ravi Amravati in 2017 on optimizing lysosomal inhibitors for the treatment of advanced cancers, including colorectal and pancreatic. He next served as a staff scientist at the Worcester Institute in the lab of Dr. Meinhard Perlin until 2020, where he studied mechanisms of acquired resistance to combination BRAF and MEK inhibitor therapy and studied mechanisms, in cutaneous melanomas by extensively using patient-derived xenografts models. He joined the faculty of the Department of Biochemistry and Molecular Biology at Johns Hopkins Bloomberg School of Public Health in 2020, and currently leads a group focused on rare melanomas, including acrolentiginous melanomas, where we know that new therapy approaches are urgently needed. So without further ado, Dr. Vito Rebecca.
Thanks a lot, Vissy, for the wonderful introduction. And hello, everybody. It's my pleasure to share our laboratory's research interests and work with you. So my lab began in 2020, and yeah, we focus on understanding resistance and drivers of metastasis in a very understudied type of melanoma called acrolentiginous melanoma. So melanoma arises from the malignant transformation of melanocytes, which are the pigment-producing cells of your skin, and it represents a major burden to public health. It's the deadliest form of skin cancer. Its incidence continues to rise over the last few decades. It remains one of the few advanced cancers that continues to rise in incidence. This year, about 100,000 new cases are estimated in the United States, and it costs the U.S. healthcare system more than $5.7 billion. Something interesting about melanoma is since it comes from melanocytes, and melanocytes are found all over your body, depending where anatomically that melanocyte exists, that becomes transformed into a melanoma, dictates the type of melanoma you have. So the most common types of cutaneous melanoma are superficial spreading, lentigo maligna, and nodular, with superficial spreading representing the most common type of melanoma in Caucasian European descent populations, the rarest form in populations of color. In contrast, acrolentiginous melanoma comes where the sun doesn't shine. It's on the palms of your hand, the nail beds, and most commonly on the bottom of your foot. And so this is the rarest form in European Caucasian populations, but represents the most common type in populations of color. So these are patients of Hispanic, African, or Asian descent. If you get a transformed melanocyte in the eye, there's also uveal melanoma, which is relatively rare and difficult to treat. If your melanocyte that got transformed is in your mouth or other mucosal regions, you have mucosal melanoma, which is also very difficult to treat. And so these are all rare melanomas that really need more study because the current state of the art is just not effective. But like I said, our lab focuses primarily on acrolentiginous. Some of the reasons for that is because it's the deadliest form of cutaneous melanoma in 5-year overall survival. And also there's rampant healthcare racial disparities that have persisted for patients with acromelanoma. And so here, if we look at the 5-year survival rates of the acromelanoma patient population and stratify by race ethnicity, we find that patients that are Black, Hispanic, White, or Asian Pacific Islander suffer significantly worse outcomes compared to non-Hispanic whites. And when you normalize for the tumor thickness and stage of presentation, this trend holds, suggesting that in addition to potential socioeconomic reasons for these disparities, there may also be biological drivers that remain to be studied. So not only do these disparities exist, they've actually worsened over the last few decades for patients of color versus non-Hispanic whites. And so in the last few decades in the melanoma field, there's been many modern targeted therapies and immunotherapies that have been FDA approved and brought into the clinic. However, the greatest increase in melanoma-specific survival was really experienced by non-Hispanic whites. And so part of the reason this is so stems from poor clinical representation. In some of these landmark clinical trials that led to FDA approval for new therapies in melanoma, including this BRIM-3 trial in 2011, 99.9% of patients were white. There was only one patient that wasn't white. It was one Asian patient. This checkmate 067 led to a landmark FDA approval in 2014 of combination immune checkpoint blockade with anti-CTLA-4 and anti-PD-1. And again, 97.5% of these patients were white. So it's not too much of a surprise that patients of color don't respond as well to these treatments when the clinical trials designed to determine whether this would have, efficacy in the general population did not have the general population represented. Also, beyond the clinical representation problems is the problems in terms of poor preclinical representation. So in the way of cell lines that are used in the laboratory, there's only 25 acromelanoma cell lines that exist in the community, and 23 of them are from non-Hispanic white patients. And so you can imagine the way our system is built. We study in the laboratory to try to understand potential new therapies, therapy combinations that are effective enough that should be tried in the clinic, but the beginning is already not representing the general population. So to make sure that any treatments we try to translate into the clinic are potentially geared to help as many patients as possible across race, ethnicity. So to attack that major gap in the field, our laboratory has focused on trying to understand potential differential biological mechanisms that are enriched between these different cell lines, depending on the race and ethnicity the patient the cell line came from. And so of those only 2 cell lines that are from non-Hispanic white, we have those 2 Hispanic cell lines, and we've done RNA-seq compared to a collection of European Caucasian acromelanoma cell lines. And so this exercise alone has already revealed more than 850 differentially expressed genes between those acro models derived from Hispanic and non-Hispanic white patients. Our laboratory at the moment is moving forward to investigate differentially expressed molecular mechanisms that we're trying to first understand by gene set enrichment analysis, and then validating potential biological drivers of these disparities. And our lab just recently also established the first now acromelanoma cell line derived from a Black patient. Sadly, and it shouldn't be this way, it's the only one that currently exists, but we're also putting this into the fold with these other models to see if there's potential differences across race and ethnicity between Hispanic, Black, and then compared to the European Caucasian. But so here's an overview of our lab's research. So we're interested in understanding acromelanoma cell intrinsic mechanisms as well as cell extrinsic mechanisms induced by the microenvironment. So within these acromelanoma cells, we're studying the signaling plasticity, the lineage plasticity. Interestingly, these melanoma cells, their immediate ancestor is a melanocyte, but their more distant ancestor is a neural crest stem cell in the skin. And there's been some studies we've shown that they can actually de-differentiate back to their more distant ancestors, the stem cell rather than melanocyte, and that helps aid their escape in therapy and metastasis. We're also interested in metabolic plasticity. In the way of cell extrinsic mechanisms, since the bottom of the foot is the most common site for acromelanoma, we are deeply characterizing that foot tumor immune microenvironment. There's some interesting differences between the skin of the bottom of the foot versus skin at other sites. It's thicker, it's more rich in collagen, it's stiffer. And so we're trying to understand how those biomechanical properties might be impacting the immune landscape in that environment. And that has implications for immune checkpoint blockade and how the metastatic biology is influenced by those biomechanical properties. And of course, then we're also looking at how these properties change across race ethnicity. And in terms of therapy resistance mechanisms, we're looking to see how these different mechanisms in acro might attribute to standard of care therapy for melanoma, which includes BRAF MEK inhibitor therapy, immune checkpoint blockade, as well as CDK4/6 inhibitors. So our lab is also trying to understand what might be driving these acromelanoma cells to metastasize from the foot to the other sites of the body. And at the moment, this driver landscape is poorly understood. What we know in the clinic is that those acromelanomas that arise in the feet, they most commonly metastasize to tumor draining lymph nodes, followed by lung, liver, scalp, as well as the contralateral limb. And so this is a nice little figure that Visi actually made for us, and we appreciate. But some of the reasons why that driver landscape is so poorly understood is that genetically engineered mouse models of metastatic acromelanoma do not currently exist, and orthotopic mouse models of metastatic acromelanoma do not currently exist. And so for this latter part is something our lab has focused on for the last 2 or so years, trying to optimize the first-in-class orthotopic mouse model of metastatic acro so that we can begin understanding that metastasis driver landscape. So the way we approach this is we took two previously created genetically engineered mouse models of just melanoma. They could be any melanoma. These are the genotypes that reflect significant portions of the acromelanoma patient population. And so what we did was we functionalized these mouse melanoma cell lines with M-Cherry as well as luciferase, through luciferase allowing us to do intravital imaging to get a sense of what's happening metastatically. We took these mouse melanoma cell lines and we implanted them either into the spot Caucasian European descent patients get their melanomas, which is more these non-plantar regions of the flank, or where these populations of color more frequently get their melanomas, which is the bottom of the foot, also known as plantar skin. And so we wanted to understand, is there any biological difference? Is there a consequence to the same melanoma cells being injected in one anatomic site or another? And so when we first look at the ability of those primary tumors to grow, interestingly, those tumors implanted in the foot grow significantly slower than those tumors that were implanted in the flank. Possibly could be because of space constraints, but we're also trying to investigate if maybe something in that microenvironment is priming that slower proliferative capacity. Interestingly, when we look at the metastatic consequences, we found that those tumors that were implanted in the foot, I don't know if you can see that because this thing is like in the way. Those tumors that were implanted in the foot had a significantly elevated capacity to metastasize to the liver compared to those same melanoma cells implanted into the flank. And so this was very exciting to us. We wanted to make sure it's not just an artifact of using mouse melanoma cells. So we repeated this exercise now using human acromelanoma cells. So here we use the WM4324, which was originally derived from the foot of an acromelanoma patient. We again functionalized it with M-Cherry luciferase. And we now implanted into NSG immune deficient mice, since you can't have an immune system with human cells, it would eradicate them. And so what we did was we looked again at the differences in primary tumor growth, which repeated what we saw with the YUM cells, that these human acromelanoma cells grew much slower in the foot versus flank. And interestingly, again, when we look at the metastatic capacity, we found that those tumor cells implanted in the foot, in this case now, were more metastatic to the lung as well as the brain compared to those same tumor cells in the flank. So really exciting to us. Obviously, we're very interested into why, and this is a completely wide open field. No one's ever studied what biological mechanisms could be contributing to this metastatic phenotype. So to begin approaching this, we performed bulk RNA-seq on the tumor cells that were implanted either into the foot plantar skin or the flank non-plantar skin. We found a great deal of differentially expressed genes. Interestingly, some melanoma markers such as SOX10 were significantly enriched in those tumors of the foot versus flank. HOX13 was also something we found interesting because it's actually involved during development in the formation of limbs. And so interestingly, it appears that these melanoma cells can determine where in the body they are anatomically, and they know that they are in the limb and express the appropriate HOX gene. We also looked at invasive signatures that were enriched by gene set enrichment analysis, as well as cell motility, which fits with the metastasis data we observed. We also observed this interesting enrichment in the collagen degradation signature, which fits with the fact that the skin of the foot is much more collagen dense compared to the skin of the flank. And so fitting that as well was a significant enrichment in this enzyme called cathepsin K. And so cathepsin K is an enzyme that's secreted from the lysosome into the extracellular space, and it actually has the capacity to degrade triple helical fibrillar collagens and allow cells to internalize through macropinocytosis. Is someone talking? I'm sorry if I saw a question in the chat. I wasn't sure if someone was trying to tell me something. Can everybody hear me?
Yeah, you're good. You're good.
Yes, we can hear you.
Sorry about that. So cathepsin K is actually an enzyme that's secreted into the extracellular space and can degrade collagen to allow recycling through macropinocytosis to fuel metastasis and other cancers. And so we were excited with the signatures of cathepsin K, validated that indeed it's increased at the protein level in the tumors of the foot versus non-plantar skin. And we also ensured that the active form of cathepsin K is also significantly enriched at the protein level in these tumors of the foot versus flank. And so we just recently got funded by a Young Investigator Award to test the hypothesis that it's cathepsin K that is driving this metastatic phenotype in these tumors implanted in the foot. So that's our work in metastasis. We're also interested in trying to develop better therapy strategies for these acromelanoma patients. So there are some differences in the genomic landscape of acral versus superficial spreading. Superficial spreading, again, the most common in Caucasian populations, there's 50% frequency of BRAF mutations. And this is important because there's really effective FDA-approved BRAF plus MEK inhibitor regimens that save lives and has a response rate of 76%. But only 20% of acromelanoma patients have this mutation. So the majority of patients with acro are ineligible for that BRAF inhibitor. Further, we found with a study done here at Hopkins that those few patients with BRAF mutations that are acro also have lower response rates to BRAF inhibition compared to their BRAF mutant superficial spreading counterparts. And the mechanisms here are completely unknown. And so a PhD student in our laboratory, Marie, is actually focusing as part of her dissertation work to understand why do acromelanoma cells with BRAF mutations not respond to the same extent as their superficial spreading counterparts. Acromelanomas, because they're also on parts of your body where the sun doesn't shine as much, they have a lower mutational burden. And this is significant because there's then a lower response rate to immune checkpoint blockade. People believe that that lower mutational burden, that lower neoepitope landscape might be mechanistically why there's a lower response rate, but it hasn't been tested preclinically. And so a hypothesis that a master student in our laboratory is testing in Samaya is whether or not the unique immune landscape of the foot and maybe the unique biomechanical forces of the skin of the foot might be contributing also to that lower response to immune checkpoint blockade. But altogether, there's, effective therapy strategies tailored specifically for acromelanoma patients is urgently needed. And so in a quick little story that we just recently published, we focused upon this finding that 60 to 80% of acromelanoma patients have CDK4 pathway alterations. And these different alterations result in a hyperactivated cell cycle, where the brakes of the cell cycle are commonly lost and the gas pedal of the cell cycle is commonly amplified, suggesting that these cells might be sensitive to a CDK4/6 inhibitor. Also, if you look at patients, those patients with acro that have CDK4 amplification also have worse outcomes, suggesting that this might be functionally important for the survival of these patients. And so that has inspired the use of a CDK4/6 inhibitor, palbociclib. And there was data also published that PDX models of acro that have these alterations are much more sensitive than PDX models that are wild type. So this helped select which patients of acro would actually receive this clinical trial inhibitor. Only patients with CDK4/6 amplifications. All to say, this phase 2 clinical trial was not a success. The median for progression-free survival was only 2.2 months. This suggests that rapid acquisition of a resistance to CDK4/6 inhibition is occurring. The trial did not consider RB expression, which is critical because CDK4/6 inhibition doesn't do anything if RB is not there. But importantly, not a single report reporting CDK4/6 inhibitor resistance in the context of acromelanoma was ever previously published. And so that was a gap our laboratory focused on the last 2 or 3 years, and Visi was a great help and was also a co-author. So to understand how these cells are escaping CDK4/6 inhibition, we first performed some in vivo PDX studies using 3 different PDX models of acro. We implanted them into mice, began treating them when they were palpable with either vehicle control in black or the clinical grade CDK4/6 inhibitor palbociclib in red. We found that 1 out of the 3 models had some activity, but clearly the tumor cells are still growing, so there's definitely resistance to be studied. We took the protein lysate from these in vivo models and performed reverse phase protein array, which is essentially a Western blot on a chip. And so it allows you to look at over 400 different total and phosphoproteins. And so this exercise allowed us to see that a lot of old friends in the cutaneous melanoma field were being enriched as resistance mechanisms, again, in acromelanoma. And so Marie Portualo, a PhD student, is looking at the role autophagy might be serving in resistance to CDK4/6, since these canonical ATG4, ATG5 autophagy genes were enriched. Bailey Robertson, another PhD student in the lab, is looking at the biomechanical pathway signaled by SRC-YAP, since we had enrichment of YAP and SRC as a resistance mechanism. Jeremy Bravo, another PhD student in the lab, is looking at the role of the AKT pathway in resistance because of this enrichment of phospho-AKT. And then finally, Kaz, a senior lab coordinator in our lab, was focusing on the role the MAP kinase pathway might be serving in resistance because of this significant enrichment in phospho-ERK we also saw in the context of resistance. And so to be brief, what Kaz saw was performing some time titration experiments. She found that there was a robust hyperactivation of the MAP kinase pathway as seen by phospho-ERK increases across our cell line panel of 4 different cell lines, as well as downstream effector of phospho-ERK, cyclin D. And so cyclin D forms a trimeric complex with CDK4, CDK6. So philosophically, it looks like the tumor cells, because they're losing CDK4, CDK6 activity, they're increasing that third leg of the tripod to continue their cell cycle progression. And we tested a hypothesis that potentially targeting then upstream ERK activity plus CDK4/6 inhibition, whether it would have therapeutic utility. And so to do this, we used we incorporated a clinical grade MEK inhibitor, trametinib, in combination with the palbociclib. And so by Western blot across a panel of cell lines, we found that the combination of a CDK4/6 inhibitor and a MEK inhibitor caused the greatest decrease in cell cycle machinery, as well as the greatest induction of apoptosis, as seen by Cleve-PARP. We also performed 3D spheroid assays where we make these little 3D kind of little organoids and implant them into collagen type 1 because it's the most common type of collagen in our skin. And we find that the greatest cytotoxicity seen as this red intensity is by the combination of CDK4/6 plus MEK compared to CDK4 alone. It appears that MEK inhibitor is what's really driving the cytotoxic effect, while the CDK4/6 inhibitor is what's driving the cytostatic effects. Long-term colony formation assays revealed that the greatest durability was with the combination of MEK and CDK4/6 inhibition. And we also had the greatest ability to inhibit the proliferative capacity, as seen by the greatest decrease in EDU positivity with the combination of palbo and trametinib versus either agent alone. So this is all in vitro studies. We next wanted to see whether in vivo this would have utility. So Kaz implanted different PDX models into mice. And when they were palpable, she began treating with either the palbociclib CDK4/6 inhibitor or the trametinib MEK inhibitor. What she found in 2 different models of acromelanoma was that although single agent with CDK4/6 or MEK could have some activity, the most robust, long-lasting activity was with the combination of a MEK and CDK4/6 inhibitor. And when we checked the tumor tissue, we could confirm that we are most significantly inhibiting the proliferative capacity of these tumor cells with the combination, as seen by Ki-67 positivity. And so from these results, we're really excited, and we're trying to launch a clinical trial that Visi was also trying to help us figure out some of the paperwork with a dermatologist here at Hopkins named Crystal Lagu. So in summary, patients with acromelanoma suffer poor outcomes, and the metastasis and therapy resistance landscapes remain poorly described. We hypothesized that distinct biological drivers underlie, at least in part, the racial disparities that are observed in outcome. We hypothesized that there's something unique biomechanically about the plantar skin microenvironment that is also promoting metastasis and therapy resistance. CDK4 pathway alterations are common in acral, but CDK4/6 inhibition as a single agent does not confer durable clinical activity. And in our most recent story, we find that hyperactivation of ERK following exposure to CDK4/6 inhibition occurs. And this is functionally promoting resistance because when we add a MEK inhibitor, we could increase the efficacy of the treatment. And future directions include really digging deep into trying to understand those biological drivers of racial disparities in acral and melanoma in general. Understanding the role age might have also in the plantar skin microenvironment. We've done some studies with old mice and young mice and find that the metastatic pattern is interestingly very different. As well as understanding the epigenetic mechanisms that might be primed by that unique environment in the plantar skin versus non-plantar skin. So here's the team that does all the work, the A team. We'd like to thank all of our funders, as well as all the great collaborators we have inside and outside of Hopkins. And then finally, a thank you to Visi. We had a really nice study also that she did while she was with us last summer. It's crazy how fast Visi can write a great paper, but this was trying to improve the public awareness of acromelanoma, because the way people look for melanoma in general, that's common in European Caucasian patients, there's something called the ABCs, but those ABCs are not relevant in acral. So there's this nice cube system. Visi made this great story and this great infographic, and just to try to make people aware, you should check the bottom of your feet, the palms of your hand, because there might be something hiding there. And so with that, I'll take any questions, and thanks so much for the time.
Thank you so much, Dr. Rebecca. Just because, for the sake of time and the structure of the panel, questions are super welcome. We're just going to hold them to the end and, throw the questions out to you, Dr. Huggins, Dr. Kindred as well. So thank you so much for that. We're going to invite Dr. Kindred, Dr. Chesahna Kindred, to share her screen. So Vito, you could switch over. That would be awesome. And just to kind of, change pace, Dr. Kindred is a board-certified dermatologist MD,
Vicky,
MBA.
it's okay. No worries. Don't worry about it because you don't have to introduce
Okay.
me. I know we're short on time. I want to make sure we have enough time for Dr. Huggins. So I'm a derm. I have my practice, specialize in hair loss, trained at Howard, did a bunch of stuff, but we're gonna leave it at that. So what I chose to do was to talk about my passion, which is hair loss, but really just limited to the super advanced, more forward things, especially since there are medical students in the audience. So there are things I had to memorize that I thought was completely irrelevant, and I use it every day. So I chose for you guys to um, talk about what's coming. And I love this quote, and the quote is: "The future of medicine is not more medications, but it's our own cells." And we just had a really great lecture by Dr. Rebecca about just how important cells are, be it good or bad. So we'll cover something that's kind of old, platelet-rich plasma, something, you know, in the present day, if you will, laser assisted delivery of growth factors and exosomes, and then some promising methods that are coming. So, firstly, platelet rich plasma or platelet rich fibrin matrix is what I use. We're really taking growth factors whose job is to fix, heal, and repair stuff. And we use that in the hair because it'll prolong anagen, which is the growth phase of the hair. There's about 7 or 8 different systems. They're all very different. But for those of us that are hair geeks, we kind of know exactly what we want to look for. For me, I biopsy all of my patients. So if I say a patient has a diagnosis, I know the diagnosis, and she has traction alopecia, which typically we have to oftentimes go straight to hair restoration or hair transplantation. But with PRFM, platelet-rich fibrin matrix, we're able to, as this patient said, get her edges back, and she's a lot more comfortable wearing her own hair, and we're able to get her out of wigs and weaves. Laser, what we're referring here is using different types of lasers to make the scalp more absorbable, creating microscopic channels. And sometimes that alone can trigger the wound healing cascade that can maybe release some growth factors that repair the follicles. I use what's on here, Thulium 1927 laser, that I'm going to demonstrate in a second. And then the newest technology I've come across is their sonic waves used to separate the cells, and they allow the delivery of different serums. So the procedure that I do, or one of them that I do in the office, we just run the laser over the scalp, and it creates a microscopic channel. And this channel ends right at the area of the bulge. The bulge is where the stem cells or mother cells are that replenishes the different cells of the follicle. Then we take growth factors, not from the patient's blood, as would be the case with PRP. We take growth factors from the lab, and we just massage it in, and those growth factors go right down at the level of the bulge. One of my most painless things that I can do to help regenerate growth. And here's a case of a patient with androgenetic alopecia. We didn't get all of her hair back, but certainly a significant amount using this method. Then there's more promising methods. There's autologous dermal sheath cup cells using adipocytes to help hair to grow. My super duper favorite, which is extracellular vesicles, but right now it's been banned by the FDA. So hopefully something will change in the future. And this is an example with extracellular vessels. So she has biopsy proven CCCA, central centrifugal cicatricial alopecia, scarring. And in one treatment with extracellular vessel, also called exosomes, this is the result that we got. Is my absolute favorite. I'm completely looking forward to when exosomes are back on the map. And we did so by injecting it. And this was some years ago. And hopefully this is something for the med students when you guys are out and about. If any of you decide to be a hair geek like me, it's something you'll be able to add to your toolbox. Sometimes the patient doesn't need such advanced things. So something that's a little bit advanced for the field of dermatology is that I'm the first dermatologist to have a full service hair salon in-house. And this is the stylist, Susan Peterkin. So here's an example. This is a patient. She had CCCA and traction alopecia. This is how she presented to me. Of course, she wears a wig or a scarf or a hat when she's out and about. And after medical treatment, maybe 3 to 6 months later, I got her to this point, which by any dermatologist standard, this is great. But by social standards, she is still wearing a wig. Well, she was also seeing the stylist in my practice, and she was able to walk out of the out of the practice without a wig. And if you see, she has the same shirt on in the second and the third picture. This is the same day. So it's a huge impact that can occur if you have a really good relationship with the stylist, if you become a hair geek. And so there's also the research arm of our practice. So what I realized is as medications become more and more precise, if those of us, if our patients with skin of color are not included, then we'll continue to have more and more medications that just don't work for us. As Dr. Rebecca just pointed out, I mean, he pointed it out several different ways, but BRAF mutations, for example, and the inhibitors. So we're starting to actually do clinical research in hair loss. I first published a case with baricitinib and CCCA, and on the right you see the before and after. And now we're actually going to run that clinical trial. And then I've also trained a few other dermatologists to start running clinical trials, particularly those of us that are culturally competent. And it's going to come to start creating clinical trials, investigator initiated trials where Blacks, Latinx, Indigenous, etc., carry the burden of the disease. So that way they're participants in the trials. And that way we can actually make a greater change, a real ripple effect in the field of dermatology. So the way that my practice is set up, it's the full Kindred Hair and Skin Center. Then there's the salon, the hair transplantation arm, and then the research arm. So I'd like to thank Vissy for inviting me to give a talk, and looking forward to hearing Dr. Huggins talk next.
Thank you so much, Dr. Kindred. That was fantastic. For the sake of time, I'm not going to belabor it too much. I would like to introduce Dr. Richard Huggins of Henry Ford Health. And before I pivot over to him and he can share his screen, Q&A might be a little bit limited this time around for time. So I'm going to put the email address where you can email any questions that you might have that we may not get to, and answers will be posted afterwards. But without further ado, Dr. Huggins.
Thank you, Vissy. And Dr. Kindred was so efficient in her presentation. I'll try to do the same in mine, that we may have some time for Q&A. So let me get my screen up. Okay. All right. So I'll go ahead. Again, Richard Huggins. I'm going to speak to you today about hidradenitis suppurativa and vitiligo, give a brief overview of the conditions, and then also discuss some specific considerations for the African American population. So starting with hidradenitis suppurativa, or HS, I treat patients with HS in Henry Ford's HS clinic, which was founded in 2008. And in that time, we have since then, we've become an internationally recognized HS treatment center. We're actually the largest referral center in North America, and more than half of our patients are African American, in large part because we're based in Detroit, Michigan. I've been seeing patients in this clinic since 2012. And for those of you who are not familiar with HS, this is a chronic disease of the hair follicle, resulting in recurring nodules and sinus tunnels, primarily in the body folds. So if you can't imagine how much this can impair someone's quality of life, patients with HS have been found to have worse quality of life than any other common, are we not? Oh, there we go. Any other common skin condition, worse than patients with type 2 diabetes, worse than patients who have heart attacks, and patients with HS have worse quality of life than the average patient with a malignancy. So real significantly impaired quality of life. The prevalence of HS seems to range between 0.1 and 4% of the population. It tends to develop in the 20s or 30s of patients' lives. It's more common in females, but worse in males. And being of African descent is a risk factor for HS. Briefly talking about some of the treatments. For any patient with HS, we try to discuss any relevant lifestyle factors and alternative therapies. So things like smoking cessation, substantial weight loss if they're overweight, avoiding dairy, engaging in a low glycemic index diet, and taking supplements such as zinc. For patients who are really flared up and in so much pain that they can't function, we try to make use of steroids, either in the oral or intralesional forms, and incision and drainage can be done to acutely manage HS as well. Other treatments are more based on the specific type of HS. So earlier stage HS, or the nodule stage, photographs are here of that are shown here. So treating this stage of HS, we use a lot of topical antibiotics. We use single oral antibiotics. And then there are some cases when we try to make use of hair removal lasers, such as the Nd:YAG for this stage of HS. With more advanced HS, patients can develop sinus tunnels, and those can either be isolated, like they are in this photograph, or interconnected, as they are, as is shown here. So with more late stage HS, we still make use of systemic antibiotics, but more commonly we'll use combinations of 2 or even 3 antibiotics at the same time. Also make use of surgical options, such as sinus tunnel deroofing, which is shown here, where we'll go in and open up a sinus tunnel. This is mainly used for isolated sinus tracts. But when the tracks start to overlap and become interconnected, the surgical approach of choice would be excision, and that can be done with the CO2 laser, as is shown here. It can also be done with just a regular scalpel. Medically, treating advanced HS for more difficult, stubborn cases, we make use of a variety of biologics or IV antibiotics, most commonly ertapenem. So specifically, how HS impacts African Americans, I said earlier that being of African descent is a risk factor. Digging into that a little deeper, African Americans, Blacks have a three higher prevalence of HS compared to their white counterparts. And not only that, but Blacks seem to exhibit more severe HS compared to whites. Now, in the general population, it takes about 7 years from the time that a patient with HS develops their symptoms until they are properly diagnosed. Well, in Blacks, this diagnostic delay is about 1.6 years later even than it is in whites. So the things I do to try to address this disparity is mainly, addressing HS in general. I work in Detroit. We see a lot of HS patients who are of African descent. And the more, I'm able to make an impact on HS, it'll exponentially affect the African Americans. And so I try to do things like spread awareness about the condition by speaking to other medical professionals or budding future medical professionals, as the case today. And then the key things I try to pass along are how to differentiate between HS and infection, which is what is most commonly misdiagnosed as. And then I try to pass along some of the initial treatments so that non-HS specialists can handle some of the more straightforward and milder cases, or in the severe cases, they can tide the patients over until they're able to see an HS specialist like myself. And then I work with a lot of residents, dermatology residents at Henry Ford, to teach them how to handle even the more complicated cases, which, as we mentioned earlier, are more likely to be Black. And then I support and refer patients to HS support groups, such as the Hope for HS group, which was founded in Detroit. and had taken a hiatus for COVID, but thanks to Rachel Krev, one of our hosts today, we've been able to bring this group back to Detroit as of this past summer, and we have a meeting coming up in a couple months, so definitely send your HS patients over for that if you know of any. Shifting over, this should have been in the beginning, but these are my disclosures, which are mainly relevant for vitiligo. I work on a lot of vitiligo clinical trials. And just briefly, my history of vitiligo, it's been an interest of mine since 2005 when I was a medical student, and I did my first review paper on vitiligo. And then I've had dedicated vitiligo clinics at Henry Ford since 2012 in our Vitiligo Treatment and Research Center. I've worked with a local support group here since 2008. And then I've worked with the international organization, the Global Vitiligo Foundation, since 2015, where I'm the treasurer and also serve as the patient and support group section chairperson. So going to briefly reviewing vitiligo, this is acquired white spots that appear in various locations on the body. Between 0.5 and 2% of the world's population are affected. There is no racial or gender predominance. And this is the disease that Michael Jackson is believed to have had. In terms of how vitiligo develops, ultimately, patients with vitiligo experience an absence of melanocytes or skin pigment producing cells in the epidermis, the top layer of their skin in the affected areas. There are multiple factors that play into this. There's a slight genetic predisposition where 6% of patients have a first-degree relative with the disease. So clearly other factors are important. And autoimmunity is certainly a key factor, with T cells attacking the melanocytes playing a key, being a key step in the development of the condition. It's kind of the opposite of melanoma that Dr. Rebecca was speaking about earlier, where we're destroying the melanocytes instead of allowing them to reproduce uncontrollably. So briefly, the subtypes of vitiligo, we have focal vitiligo, where the vitiligo is confined to a limited area. I write on here that it's non-dermatomal because this focal vitiligo is contrasted with segmental vitiligo, which is also focal, but it's in a dermatomal distribution. The dermatomes are areas of the skin that are innervated by the same spinal nerve root, and segmental vitiligo seems to kind of follow this pattern. Generalized vitiligo is where you have widespread involvement, and it's usually symmetric. So vitiligo can cause a lot of psychosocial issues because of the facts that it obviously can affect your appearance. It's unpredictable and often progressive. Even though we're coming out with many more treatments, there are inevitably going to be some individuals that we can't treat effectively. And even the folks that we are able to treat, the treatments are really slow. We don't expect any difference in vitiligo in less than 2 or 3 months. So because of this, patients with vitiligo can have psychosocial issues like low self-esteem or embarrassment, increased marital difficulties, higher divorce rates, and sexual difficulties are pretty common depending on the area affected. And some patients with vitiligo have frank psychopathology, with almost 60% of vitiligo patients reporting having been diagnosed with some mental condition. That includes 28.7 reporting of diagnosis of anxiety. That's compared to 8% in the general adult population. And when it comes to depression, about a quarter of vitiligo patients report having been diagnosed with depression, compared to 6% of the general population. And 55% of vitiligo patients have symptoms of depression as measured by a depression questionnaire. So a lot of undiagnosed depression in the vitiligo community as well. Briefly reviewing management. Most commonly, we treat vitiligo with topical preparations. This is more so for focal vitiligo, but can also be used for generalized vitiligo. We use topical steroids, and these are the most cost-effective or accessible topicals. Calcineurin inhibitors, a few examples are listed here. These have minimal side effects, but are a little more expensive than the topical corticosteroids. And then the summer before last, we finally had ruxolitinib or Opzelura approved as the first medication approved by the FDA for the repigmentation of vitiligo. So really excited about that. This has the best efficacy of all our topicals, but it's also the most effective. And then any of these topicals are going to be more effective when you combine them with phototherapy, which I'll discuss next. So we have whole body phototherapy. This is mostly used in generalized vitiligo. Narrow band UVB is the preferred modality for this. And we also do targeted phototherapy. That's more for localized vitiligo, most commonly using an excimer laser or light. And this works a little faster than the whole body phototherapy, but again, you can treat only limited areas. And then you can do surgical treatment for vitiligo, where you can take epidermal cells from a vitiligo patient's normal skin and transplant them as a suspension to the vitiligo lesions. Henry Ford is one of the only institutions in the country where we do this, where this procedure is done. And then specifically tying in vitiligo and African Americans, again, vitiligo affects all races at equal rates. So how is this a skin of color disease? Well, that's because it is more noticeable on darker skin. Obviously, if you have white spots, they're going to stand out a lot more if the normal skin is contrasting with them more. And not only this, but Blacks and really anyone with skin of color, their identity is often intertwined with their skin color. So when you're losing your darker skin, it can sometimes create a crisis of identity. Lee Thomas is a Detroit Fox News reporter with vitiligo who wrote a book entitled Turning White, discussing his struggles with this very crisis. There's also the issue that people may think if you have vitiligo, you're trying to bleach your skin because you are embarrassed of your racial identity. So that's another part of it. All this comes together to make it so that darker skin is a risk factor for worse quality of life, according to most studies of patients with vitiligo. And as you can imagine, physicians are only going to be so helpful with helping patients deal with these types of issues. And that's another reason why, support groups can be invaluable in vitiligo as they are in HS. So specifically what I'm doing to help try to address this, I, again, here too, try to spread awareness about vitiligo by presenting to medical professionals, training residents on how to treat it. And I do a lot of work with vitiligo support groups. I've been heavily involved in our local group for the past 16 years. Our group is mostly African American. I also help provide resources and opportunities for collaboration for all vitiligo support groups, or most of them in the US, in my role with the Global Vitiligo Foundation. And I try to serve as a bridge between individuals with vitiligo and the other stakeholders in the vitiligo space. And then I'm engaged in all types of research for vitiligo, trying to get better treatments and a cure, hopefully, for this condition. And then, like our other speakers have discussed, getting more and more skin of color patients, more African Americans in research is essential for both of the conditions I mentioned, any condition that's out there that's relevant for. So I'm a part of that effort too. So I'll end with a photograph from last summer's picnic with the local V-Strong group. Our next meeting is next month if you know of any vitiligo patients who may be interested in attending. And I thank you for your attention.
Thank you so much, Dr. Huggins, for filling us in on what's been going on and the role that you've had in that support group as well. It's fantastic. So I wanted to, on that note, open up the question period. So if anyone has any immediate questions, to put them into the chat, or shoot us an email at the website that Dr. Damsky just put in the chat as well. One thing I did want to start off of, just because there's a huge, I guess, common theme in each of your talks, is the role of community in, each of these very distinct pathologies, and with the support groups that you were mentioning, Dr. Huggins, and, Dr. Kindred, when, bringing in that full service hair salon to address the needs of your patient base. And even with you, Dr. Rebecca, talking about the need for, more adequate, more representative education amongst these topics. Is there any anecdotal feedback that you've gotten from your patients or throughout your experiences that ties into that? How do they respond to the extra support or the directed care, the directed education that they would be getting. Any thoughts on that?
I mean, I'm sure everyone is like, there's so many different ways we could go. We could go with this. I think the biggest thing I would say is, unfortunately, because of the history of Blacks in America and some of the issues that have occurred, and the tremendous betrayals of the faith that society puts into medicine. You know, a lot of people of color, Blacks in particular, are more mistrusting of medicine, of physicians, of research. And I think that's a big part of the reason that, you know, they're not involved in research to the extent that we want them to be. So, you know, I think we all play key roles in understanding that and making efforts to reach out to the community, understanding issues that they've had in the past, let them know that we're working on that, but that we need them to be involved from here going forward, so that you know, we can be as helpful as possible in our positions. We can help them as much as possible, and communicate with them about ways that we can do so.
Thank you. Thank you. Dr. Kindred, did you have anything to add about maybe from a hair perspective, what having that extra support has been able to mean for some of your patients coming through?
Yeah, that it's made me a better dermatologist, because what I found with hairstylists is patients tell the stylist the truth and lie to us, quite frankly. They have more time with the patient, and they're an excellent conduit to share information. So when I've trained one dermatologist, I've trained about 1,000 patients. The other thing I want to point out, is that the community wants to partner with us, right? So whatever idea you have for partner with the community, they are very receptive to. We just formed an organization called STRAND, stands for Stylist Training, Researching, and Networking with Dermatologists. And we're about to have a workshop where I'm grabbing dermatologists from all over to train stylists about healthy hair and scalp practices along with alopecia. So the community wants to partner with us.
It's a great question, Vissy, and something, you know, I don't have as much patient access as these other excellent panelists, but what you're doing and how you're connecting with the community is massively important. And in melanoma, like I showed, there's only one now cell line from a Black patient, two from Hispanic, and maybe part of the reason is that lack of trust, for good reason. And I would love to. I'm gonna contact each of you. I'm so happy Vissy connected us, because I would love to learn how you approach building these relationships, because at the end of the day, it's what we need to help the patients at the clinical level. So I really appreciate the work you both do.
Awesome. We've got a question in the chat here, so it's directed to all our presenters. What do you think about the intersectionality of AI in the care and diagnosis, in particular for people of color? I understand that there's a large disparity in the available data and also data collection. Do you think there's a scope for improvement to make data-driven care more equitable?
What a great pickup. I actually had a picture I created from AI on that very first slide. If you look, the thumb was off. So garbage in, garbage out. The first thing is there's not a single AI platform that does not require human input, right? So this is our time. The other thing is AI, if we don't jump on it, it's going to continue to be incredibly biased, right? So it's not something to be scared of and ignore. It's going to hurt us later. We use AI in our practice for calculating hair density, and it's tremendously better than any photo is going to show. But the key, I think, especially for skin of color, is we have to keep a seat at the table, or else it's going to be incredibly detrimental later. And we've already seen cases of that.
Thank you. Any other input on that question? Okay.
It's a good question.
I did have
Vissy, as part of this story that, you know, she recently published, that was part of it, looking at, you know, discrepancies between AI as a tool to detect the melanoma, its accuracy, and how it's really not accurate in skin of color versus So something we're doing here at Hopkins to try to make it more color blind when it comes to at least diagnosing melanomas is taking advantage of other properties of the skin, such as the stiffness of the skin and how that might change in the context of melanoma versus a benign lesion. But, there's definitely a need for efforts to make this AI issue not as bad.
Okay,
And I think
fantastic.
it's about representation, right? I mean, just the same way that AI is not going to be able to recognize these skin conditions and skin of color unless it's trained on them. It's the same thing with dermatologists in general, being able to recognize anything on skin of color that, the skin looks different, diseases look different on skin of color compared to how they look on Caucasian skin. So we need representation, of us in these specialties and making sure that people are seeing photographs of skin of color conditions, general conditions on skin of color, both in real life, as well as making sure that AI platforms get trained on that.
Okay, perfect. Thank you all so much for your insights. Just to be, again, respectful of everybody's time, any other questions, please submit to the email address that we've provided in the chat, and we will do our best to get those answered and back out to you as soon as we can. Huge thank you to Dr. Kindred, Dr. Huggins, Dr. Rebecca for taking the time to speak with all of us and to share, your insights about your work, your perspectives on treating skin of color. As we know, it's a hugely relevant area that doesn't always get the spotlight that we think it needs. And so your contribution today is greatly appreciated. And on that note, we're all free to go. Thank you so much for helping us kick off Black History Month. It's been a fantastic opportunity to have you all here.
Thanks for the opportunity.